First of all, I would like to thank the Scientific Committee and, of course, Professor Liakopoulos for the kind invitation to discuss today the current issues and the emerging therapeutic options that we have for IgA nephropathy. These are my disclosures. And I will quickly start with the knowledge that we already have that IgA is the most frequent glomerulonephritis. But also we know that now it's not considered anymore a benign disease. It's rather very serious clinical course with 40% to progress to end-stage renal disease. Indeed, the information that we currently have from the most recent publication from the UK cohort, the RADAR cohort from the UK registry, we do know that almost all patients are at risk of progression to end-stage renal disease within their lifetime, unless their eGFR decline is less than 1 ml per minute per year. And even patients throughout the 10 years from the diagnosis, they are not considered anymore low risk, the ones who have proteinuria of less than 800 milligrams per milligram, and they do have a very bad course. From the new technologies, such as genome-wide association studies, we do know now that there is a close connection between the gut and IgA nephropathy, and indeed, in identification of several genetic variants, such as GARD9 locus, as well as genes that encode cytokines that are important for mucosal immunity with IgA nephropathy, we have confirmed this close association. So from the knowledge that we do have from IgA and the gut axis, we know that in genetically predisposed patients where epigenetic factors will be affected, such as food allergens, infectious agents such as bacteria or viral or fungal agents, as well as the microbiome, which a lot of discussion has been done the last years. These patients will form the IgA, galactose deficient IgA1, and then this pathologic immunoglobulin will enter the circulation where it will be recognized by the innate immunity as a foreign molecule, and autoantibodies of class IgG and IgA mainly will be formed. Immune complexes will be composed and will be trapped and deposited in the mesangial area of the glomerulus. But now we do know that there is a fifth step in this multi-hit theory, and that is the complement activation, which is triggered by the deposition of these immune complexes. Indeed, we do know that there is an activation of the lectin and the alternative pathways of the complement system, and therefore final products of the complement will be formed. Therefore, we know now that these could be potential therapeutic targets, and at the end of my talk I will briefly discuss what is running currently and as an attempt to decrease the progression of IgA and to decrease the incidence and the progress to CKD. What about which patients are at high risk? Which patients should be under our close radar? And which patients should we indeed treat aggressively? So this information will be gathered, of course, from the kidney biopsy, and this has been graded in the MEST-C score from the Oxford classification, from where we get information regarding crescent presence or not, hypercellularity of mesangium and capillary loops, as well as elements of chronicity, such as tubular atrophy and fibrosis. But this MEST-C score has been incorporated in the international prediction tool, among other parameters, such as GFR and proteinuria, which have been validated as prognostic biomarkers for IgA, as well as data about systolic and diastolic pressure, demographic data for the patients such as age and ethnicity, as well as whether the patients were or in the past or at the time of biopsy on immunosuppressants or on maximal RAS inhibitors. Now we do know that this prediction tool, which can determine the 50% decline in eGFR or progression to end-stage kidney disease in 5 years from biopsy, the updated IgA prediction tool has been validated that it can accurately risk stratify the patients, even if we use it 2 years post-biopsy. But what about the KDIGO? What do they say? Which patients have been identified as high risk? According to KDIGO guidelines, they are high-risk patients are defined the ones which have persistent proteinuria of greater than 750 to 1 gram per day, despite the maximal blockers of RAS system for 3 years, as well as other measurements for supportive care. But according to recent data, they have been validated and compared two ways to allocate patients to immunosuppressants. In this attempt, the proteinuria level versus the prediction tool of IgA has been compared to the allocation of immunosuppressants, and it has been concluded that there is accuracy, more accuracy for the IgA prediction tool rather than proteinuria. We could not rely solely on proteinuria because there has been proved that there a larger net benefit of up to 23% and a larger net of decrease of unnecessary immunosuppressants up to 35% of the patients. So KDIGO update from 2021 regarding IgA and how we can approach patients with IgA nephropathy, they suggest that after we exclude the secondary causes of IgA nephropathy, such as viral disease, liver cirrhosis, etc., of course, we have to stratify according to the risk our patients based on the MEST-C scoring of IgA prediction tool. And therefore, if it is, there is a possibility to enroll them either in a clinical trial, if they are of high risk for progression, but all of them, low or high risk, should be, of course, initiated in conservative management, maximal conservative management, which, according to the KDIGO, is composed of very strict blood pressure with a target of systolic blood pressure of less than 120 millimeters of mercury, especially in patients who are proteinuric, as well as lifestyle modification, which are basically from sodium restriction and protein restriction, idealization of body weight, increase of physical activity, and of course avoidance of nephrotoxic agents. But even patients with, which are on maximal supportive care, and here I show data from the STOP IgA cohort, patients in the placebo arms, not only from STOP IgA, but also from other clinical trials, 50%, even on maximal conservative management, they had a risk of 50%, and they did reach end-stage renal disease 10 years post-diagnosis. So we understand that there is an unmet need, a gap in how we support our patients, and this has been confirmed from the RADAR, again, database recently, earlier this year, where in this cohort it was proved that maybe also we have to push our levels of target proteinuria to less than 1 gram. Here we see in the second column from the left that the patients who had proteinuria range from 500 milligrams to 1 gram, 31% of these patients did also end up on dialysis. Therefore, maybe in the next KDIGO guidelines, maybe it will be as a target a new level of proteinuria. As far as the duration of time, we have to say, in combination with the level of proteinuria, the lower the better, the longer the better, and indeed, in this publication it has been confirmed a relationship of non-linear dose-response relationship with no minimum duration of remission. So what are the new data regarding supportive care? The data are promising, and this landmark trial, the DAPA-CKD trial, where dapagliflozin was used, a subgroup of this trial, and specifically 270 patients, had biopsy-proven IgA nephropathy. And it was found that addition of dapagliflozin to the RAS inhibitors led to reduction of risk progression, which was defined as greater than 50% reduction of eGFR or ending up on dialysis. And indeed, the renal endpoint proved a hazard ratio of 0.23 and a reduction of urinary ACR by 26% with a very good safety profile. And therefore, they did conclude that dapagliflozin significantly reduced the risk of CKD progression in IgA nephropathy, and therefore it was fast-track approved by USA, by FDA and EMA in CKD from IgA. What about endothelin and angiotensin blockers? We know that endothelin 1 and angiotensin 2 induce inflammation, fibrosis, increased permeability in glomerular filtration barrier, vasoconstriction, and increased glomerular pressure. We do have new agents such as sparsentan, which is a dual endothelin angiotensin receptor antagonist, which has been evaluated in the PROTECT trial, which is an international double-blind active control randomized control trial, and where patients, 400 specifically with IgA biopsy-proven nephropathy, were randomized in either 400 milligrams of sparsentan versus 300 milligrams of irbesartan. Patients had an eGFR greater than 30 and proteinuria greater than 1 gram, and the duration of the study has been set to 270 weeks. In the interim analysis of 36 weeks, we do have very significant results with sparsentan, and indeed the group that received sparsentan showed a 50% reduction versus 15% reduction in the irbesartan group in the proteinuria, where the 21% of patients showed complete remission in the proteinuria level, and therefore sparsentan did receive also the approval, fast-track approval in patients with IgA nephropathy and proteinuria greater than 2 grams per day. And also that the safety profile was very satisfactory. It had only minimal peripheral edema, hypotension, and dizziness, whereas there was no hepatotoxicity or increase in heart failure. What about the corticosteroids? The big question. Where do we use them? We don't have good results from the two big trials, STOP-IgA, where it was proved that indeed it decreases the proteinuria level, but did not translate into kidney function preservation and had many side effects. Here we see the 10-year graph for the renal outcome, which is basically same as the placebo group. They do both progress in 10 years from diagnosis and from treatment, as well as testing trial. Indeed, this trial again had many side effects. It was terminated early due to side effects. They did try, although the scientists, for reduced levels instead of the initial dose that was evaluated of 0.6 to 0.8 milligrams per kilogram. They tried to reduce to 0.4, and what they saw were in this cohort, I have to mention, it was for 76% Chinese of Chinese ethnicity. There was a significant benefit of proteinuria. However, this significant level in proteinuria and in GFR, we see here the two groups of the reduced prednisone dose versus placebo. However, this proteinuria reduction was lost when it was evaluated at 3 years, as well as the benefit of the stabilization of eGFR decline was lost at 5 years. So the retesting steroids for IgA, again, the side effects in this group, the reduced dose of steroids, was decreased, but again, it was double when compared to the placebo arm. So KDIGO in the 2021 update conclude, and having in mind the two big trials of Stop IgA and testing trial, that clinical benefit of glucocorticosteroids in IgA is not established and should be given with extreme caution or avoided entirely. And therefore, it concludes that patients who have eGFR less than 30, we should consider on maximal supportive care, or patients who have greater than 30 and are considered according to the IgA prediction tool of high risk. After evaluating the toxicity risk based on obesity, of diabetes, of latent infections, we should consider maybe with caution, of course, and with discussion with the patients, the administration of steroids. But what about the new data that we have from new agents, such as topical glucocorticosteroids versus the systemic administration? And the data we have come from the NefIgArd trial, where Nefecon, which is an oral target release formulation of budesonide, it was compared to efficacy and safety. And the data that we have now is that it can significantly reduce proteinuria, both at 9 months, that was the duration of the drug administration of 16 milligrams of budesonide, but also it continued to decrease the proteinuria to 48%, even 3 months post-administration. What we can see now from the results that we have at 24 months is that there is a tendency to rebound this level of proteinuria, but yet still it is a significant difference from the placebo arm. Sorry. Also, as far as the reduction loss of eGFR, again, at 24 months, we can see that there is a significant difference between the budesonide and the placebo arm, as we had with proteinuria. As far as the adverse events, 86% of the Nefecon versus 73% with placebo, but there were no severe infections requiring hospitalization, and only 9% of patients did have to discontinue the study. So if we compare the severe effects, adverse events between the three trials, the Stop and testing and the NefIgArd, we can see the big difference in the percentages, 33 versus 11 versus only 1% of serious adverse events in the NefIgArd trial, with only mild infections in 2% and no need for hospitalization in these patients. So comparing the systemic glucocorticosteroids versus delayed release budesonide, probably the difference in the systemic adverse events are due to the 90% cleared, that 90% are cleared by first liver passage and giving less systemic serious adverse events in the budesonide arm. But which patients will indeed react, and which patient will benefit from the steroids? It looks that we do have to insist on the levels of activity that we get from the biopsy, and we have to evaluate also the levels of chronicity. And indeed, higher glomerular infiltrates were significantly associated with increased probability of response to immunosuppression in adjusted analysis. So the MES score we use to select patients for C and treatment, corticosteroids treatment, active lesions, glomerular macrophages, association with persistent or severe hematuria, rapid eGFR decline, and active features. So all of these parameters should be evaluated, and we should have them in mind when treating patients. According to the emerging therapies that we have, and currently are running phase 2 and phase 3 trials regarding, first of all, inhibition of immune complex activation of the complement system. APPLAUSE IgA trial as well as Artemis trial are on the way, and we're expecting for iptacopan and narsoplimab interesting, probably, results. And indeed, here we see the new agents and the levels of the complement system that are blocking. Very quickly, the APPLAUSE IgA study is on the way, and it will evaluate the benefit and safety of iptacopan in reducing complement-mediated kidney damage. Iptacopan is a proximal complement inhibitor that specifically binds to factor B. As far as the interim analysis, the safety and efficacy of narsoplimab has been suggesting that it is safe and well tolerated, and may result in clinically meaningful reduction in proteinuria and stability of eGFR. And finally, for C5a receptor inhibitor, the avacopan, again, here we do have promising results to see in the near future. For the BAFF-APRIL signaling, Janus trial is in phase 2b. Here we see the Janus RCT. And the initial results that we have is that atacicept shows a 60% reduction in galactose-deficient IgA1, as well as 25% reduction in proteinuria. So closing this talk, I would like to see what does the future hold. Probably we should identify earlier or diagnose earlier patients. We should definitely enroll patients in clinical trials, or we should try to identify. Novel biomarkers are needed, yet we don't have them in clinical practice, such as levels of IgA1 or levels of autoantibodies should maybe is something to look at. Of course, we have to personalize the best therapy with regarding to different treatments at different stages, or concomitant or sequential therapies. And maybe we should repeat our biopsy in order to determine the assessment of treatment and the response to treatment. Of course, the big questions are, what about the pediatric population, which are not included in the trials, or the transplant population? What about IgA vasculitis nephropathy? And of course, AI, whether pathomics, which are automated morphometry and comprehensive quantitative data, could predict who will respond to corticosteroids. So closing, I should leave you with this, that this is an awesome time to be a nephrologist. We are at an entry level of an explosion in new therapies that show very little safety concern, and yet are providing us the mechanisms to move in a direction, hopefully, of both early and precise treatment for individual patients. Thank you very much.